First, I would like to thank the organizing committee for a kind invitation to join this wonderful meeting. And my session title will be, Does Antimicrobial Stewardship Work in Asia? With that, over the next 25 minutes or so, I would like to share with you the review of the evidence of antimicrobial stewardship in Asia, as well as the consensus that has been developed in Asia, as well as the need to integrating to strengthen this work in Asia. To be able to answer whether antimicrobial stewardship work in Asia, I would like yourself to vote for the question that's listed in here. Does the antibiotic stewardship help reduce the following outcome in Asia? Particularly, you voting in your view in the outcome of your hospital quietly, because this is a videotape session. A, antibiotic consumption cause MDR mortality. Yes, 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 yes. B, yes, 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 no. C, yes, yes, no, no. D, yes, no, no, no. E, no, 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 no. You can vote. I would like to start by saying that antibiotic stewardship evidence in Asia is not new, and there are many data since 1970 and 1980, and this is a recent review and meta-analysis to evaluate the impact of ASP on various outcomes, including the patient care outcome, antibiotic prescription, microbiology outcome, as well as the antibiotic expenditures as well. The data is fairly distributed across the Asia Pacific region, as shown in this PowerPoint. The outcome, if you look at the mortality, if you look at the type of study, before and after study, there's no clear significant impact on the outcome on mortality. But if you look at the comparative trial in this study, you can see a clear impact on reduction in mortality already. So clearly, it would be fair to say that antibiotic stewardship did not increase mortality by any means. If you look at the impact of ASP on antimicrobial consumption, in this regard, you can see a significant impact on reduction in antibiotic consumption overall. Particularly, if you look at the carbapenem consumption, the rate of carbapenem consumption can be significantly declined to 10% or more. And this has been consistent in many studies that perform antibiotic stewardship in this region as well. The impact of antibiotic stewardship on the MDR pathogen is less clear in this region. Perhaps the study that look at the MDR as an outcome in this region is fairly limited. If you look at the outcome as the cost of the hospital, it has been also quite consistent in almost the study, suggests the same thing, that antibiotic stewardship have a tendency to reduce the cost of antibiotic use in the hospital, as shown in this PowerPoint. The intervention that commonly employed in this region, including the prospective audit and feedback, the formulary restriction, pre-authorization, while several intervention like using education, and also many intervention using things like listed in here in a fewer frequency in this region, particularly the optimization of those, the rapid use of rapid diagnostic, and use of computerized to help integrating ASP in the program has been less commonly used in this region. Another study published in year 2019 looking at multiple intervention in Asia and most of the study performed in a single center. And what they found is that the impact of ASP on the mortality may depend on the type of the study, where if you use the drug control, monitoring, formulary restriction, and IV to oral conversion, in this situation, you might have a clear impact on the mortality, where the intervention that did not use these intervention was associated with a less clear impact on mortality. If you want to look at the impact of ASP on MDRO, it's undeniable to be incorporating with all efforts of infection control and also some other measure like hand hygiene to have a significant impact on the reduction on the MDR pathogen as listed in here. The value of hospital antimicrobial stewardship program has been reviewed in a systematic review that looked at the patient outcome and the cost that listed in this PowerPoint. The value has been calculated by the outcome divided by the cost, where the cost has been summed up in the metric in here, where the patient outcome metric has been shown in the box and antibiotic metric has been shown in the box. Clearly, there is a significant impact of this program. If you look at the value of the program across all the continent, it has been quite consistent that there are some value associated with this program. But with that in mind, the data is quite limited in Asia, that more data in lower and middle income country would thus be need to inform the decision about the real impact and value of ASP in our region. I would like to move next to the evidence of control MDR GNB and correlating it with the antibiotic stewardship effort. First, it is a study that performed to evaluating the existing evidence on the control of MDR GNB, and they looked at multiple approaches, including the standard precaution, standard method, including the hand hygiene and contact precaution, comparing with the ASP, environmental cleaning, decolonization, and source control together and in combination or a single component, and look at the outcome of the MDR acquisition as well as the mortality, whether or not this outcome will be declined if you look at those components of intervention alone or in combination with the other. This is a study that has been selected to participating in this meta-analysis, and the outcome is quite clear. The standard method, including the hand hygiene and contact precaution, comparing to multiple methods combined with the standard. The more intervention you perform, the more likely chance that you are able to achieve control of MDR GNB. And in this session, I would like to share with you the impact of standard plus ASP is already approach statistical significant to reduce MDR GNB, while it is quite consistent in the black dot and in the blue dot. In RCT and non-RCT, the outcome is very similar and suggesting that there's a tendency to be successful already if you just added ASP on the program. But if you broke down into the specific pathogen for Chlebicki, the way to interpret this table is quite complicated. For example, if you want to compare for intervention with the two intervention here, you can draw the line and you can see that the rate reduction and 95% of rate reduction do favor the full intervention here. But if you look at the data critically, you will find out that the component that is very helpful to control MDR Chlebicki must incorporating environmental cleaning. While the component that stood out for Pseudomonas aeruginosa is no. You have to combine the effort together. For ESBL, it is quite interesting that no matter what the study type is, the outbreak or non-outbreak type, the outcome is quite clear that if you use the antibiotic stewardship featuring program, it will likely contain the ESBL in your study. That has been clear in the study that has been performed as well. If you're dealing with CIE, you really have no choice except integrating all intervention together to have a successful contain of CIE. So in brief, the key component for CIE, you have to practice all core component. For Acinetobacter, you have to select any intervention that featuring environmental cleaning, while ESBL, you have to select the antibiotic stewardship program as a core component, while the XDR Pseudomonas aeruginosa, there's no clear winner for the intervention that you would like to select. I would like to move next to the consensus of antibiotic stewardship in Asia Pacific, and this is the data that published that lists several evidence related to antibiotic stewardship, including the lack of the data, the lack of infrastructure, the lack of funding, the lack of support, and etc. are a key barrier listed in the Asia Pacific. With that in mind, in the guideline, I suggest you to come up with the teamwork that including the infectious disease and clinical pharmacists that should work as a core team leader, as well as the clinical microbiologist, infection control expert, and also IT person that all together should be combined and work together as a team, as a core component. The supplementary components must include the hospital administration, the nurse, and other physician involvement. And also in the guideline itself, it also asks the hospital in this region to come up with the measurement for the process and the outcome. And of course, there are a lot of measurement for the process, including the measurement of antibiotic consumption, the measurement of the appropriate use of antibiotic, the measurement of the escalation, etc., and outcome may include the length of stay, the cost, the MDR prevalence, and etc. At the bottom line, this study should be studied in this region whether or not the metric, which metric would be practical to use in this region. With that in mind, the guideline also summarize many evidence in Asia and come up with a grading recommendation and together with the quality of evidence for the reader to follow and apply in the real setting as well. I would like to move next to what are needed to be done in this region to strengthening the stewardship work. I would like to start by saying that the gap analysis has been published as a part of the consensus in Asia, where the gap has been broken down into many aspects, as you can see here, including hospital administration and many aspects, including the team, the intervention, and the guideline, the IT, the infrastructure, the education, and then you sum up the score of the gap, where C is the core component, is the component that your hospital must fulfill first, and S stands for supplementary component, where if you fulfill the C core component, you can think of doing the supplementary component as well. The way you do it is fairly straightforward. You can read the checklist and you can just check yes or no. For example, did you have the formal support of your hospital admin? Yes or no, you check the checkbox. And if your hospital has been financial support by the hospital for this work, yes or no, etc. After you scoring and you sum up, the guideline itself has this instruction on how to overcome this gap For example, if you say no to hospital administration item, it will clearly suggest you to get prioritized formal support and perform the business case to fulfill the criteria for core component and etc. And the solution has been broke down into many components of this gap analysis, as you can see in here. Gap analysis can be used to analyze the situation in your hospital, in your network, in your regional, in your country, and in multi-center, in multi-country as well. This is the example of the use of the gap analysis in the region that we found that in our network, we have the hospital that fulfill the core component of approximately 60%, but supplementary component has been fulfilled only 0%. There's no hospital that fulfills supplementary component at all. Of course, the way to look at it is to strengthening or closing the gap for the core component. Most of the hospital don't have the clinical pharmacist, microbiologist involvement, and the process and outcome measurement typically are not available. And also, you really need to regularly publish the antibiogram, while the supplementary component typically include the lack of IT, the lack of the treatment and prophylaxis guideline, the lack of unit-specific antibiogram, the lack of monitoring the process and outcome of your program. And these are the things that you should be strengthening as well. The gap analysis was utilized in a multi-center study. This is a 10 study in Asia Pacific that looked at the gap, and they found out clearly that the standard of the core component is still really difficult to meet in this region. And clearly, there are some country variation in terms of the practice of the antibiotic stewardship within the country. And of course, the strategy that tailors specific to each country are needed to strengthen the antibiotic stewardship program for each country. So the use of antibiotic stewardship has been discussed now with the use of rapid diagnostic. And this is a consensus of the rapid diagnostic testing in Asia Pacific, where the use of Asia Pacific rapid diagnostic testing has been proposed to be useful in 3 time frames. The first time frame is the initiation state of the treatment, where there are some tests listed in here, like influenza test, procalcitonin, can help you distinguish infection and non-infection, and can help you judge whether or not antibiotic should be started or not. The second state is the ongoing, is the state that there are a variety of tests that can tailor made for appropriate adjustment for a narrower spectrum antibiotic. And the test has been listed in here. And some tests also come to inform the prognosis as well. And the last time frame is the time frame that you consider the escalation or stop antibiotic. And there are a variety of tests listed in here as an alternative for these purposes and help you tailor-make the program appropriately in the antibiotic stewardship program. Of course, there are a lot of limitations with this, including the lack of infrastructure, the lack of guideline, the lack of expertise, the lack of information, and the lack of endorsement in the country, in the society guideline regarding on the use of RDT in the country level. With that in mind, procalcitonin has now been widely used in many countries, and at least there are some consensus in the PCT that integrating the PCT use in critically ill and non-critically ill with different cut point and the time frame that should use the PCT is also consistent with the use of RDT that I previously mentioned. It's the first time frame when you decide to give antibiotic, and follow-up time frame to adjust and inform prognosis, and the escalation time frame to stop antibiotic. So this has been clear in many guidelines now, and also with that in mind, there are also many barriers to the use of this test in reality, despite it is a very well recognized and well utilized test. The limitation, including the lack of information on many diseases, particularly the tropical medicine, like dengue, hemorrhagic fever, tuberculosis, and etc., as well as the logistical aspect, who will fund, and the cost, and of course the guideline and endorsement of this test also need to be assured in the national scale if you want to use this in a wide scale to have an impact in the ASP program. With that, I would like to conclude my talk by saying that there are now abundant data exists to support the role of ASP in Asia, particularly on the antimicrobial consumption, MDR, and cost. And I don't think we should do any study to confirm this anymore. But what we are doing is that despite this evidence, there are many gaps that we should perform in the gap analysis to identify the strengths and weaknesses, as well as the strategy to overcome this gap. And thus the evidence base should be built upon the data on those gaps that you still not you still unmet in the institutional, in the regional, in Asia, and in multi-country as well. With that, I would like to thank you very much for your attention. ขอบคุณครับ